Dimitrios Kantas, we are so thankful to have him in this conference. Dimitrios Kantas is a pulmonologist.
Pulmonologist. Pulmonologist.
Let's say it in English. That's the funny way. So, pulmonologist.
Okay, doctor. Just say doctor. Let's continue.
It's very important that you are a pulmonologist and an intensivist somnologist, right? During this period. So he will have some great perspective to give us. He will discuss about what we know and what we don't know about COVID-19 today. And we hope to share some of his forecastings for the future. I think it will be very informative. Thank you again, Dimitris, for giving this talk.
Okay, thank you for your kind invitation and for your time. So I'll be brief. So our topics of discussion will be COVID-19, and I'll start. The strategies. We will talk a little bit about background, epidemiology, clinical disease, infection prevention, and treatment. So regarding terminology, as you all know, this disease is caused by a virus named SARS-CoV-2, and coronavirus disease 2019 is the disease that is caused from this virus. Regarding what is an epidemic, epidemic is a disease that affects a large number of people within a community, population, or a region, a country, a continent, or something. If that lives out from that country, from that continent, etc., it's a pandemic. So what we are facing at the moment is a pandemic. Regarding coronavirus and you know how we named him coronavirus, it's because of the structure the virus has. You see this corona appearance of the virus. So this virus, let's say, it has some kind of royalty. That's why we really care about him. His structure, you see here the structure of the virus. It's mainly an RNA virus. The proteins in his surface, this is the virus. Here is the RNA. And this virus is encapsulated in an envelope. This envelope is made by some proteins like the S protein, as you see here, which mediates receptor binding and fusion. It's a major antigen. It's the main cause of the disease we have, and it's also a main target for vaccination today. The membrane protein M, which protects the virus from out of the virus attack. Sorry, what I forgot to mention is that the S protein is also the protein that binds the virus to the cells. So the M protein, it protects the virus from attacks from outside. So N protein, which is this protein, it helps the virus to replicate, and it's a possible antigen. The E protein, which is a small protein that forms the structure around the virus. And also this virus is affecting our cells, mainly the cells of the respiratory system, through the ACE2 receptor. ACE2 is for converting enzyme receptor, and it's mainly a target for at the hypertension, at the blood pressure, drugs that decrease the blood pressure of our blood. So there is a debate at the moment if blood pressure drugs they may help the virus to replicate in our body, or if they may cause, let's say, more severe disease. No clues at the moment, so it's still a matter of debate. So regarding the transmission to humans, we've known coronavirus is the last couple of years. So you see here the common human coronaviruses. All of those are detected by PCR. So those are probably unknown viruses to you, but some of you might have heard the novel coronaviruses, the severe acute respiratory syndrome coronavirus of 2003, the local outbreak in China, if you remember. Hopefully we did it good at that time, and we had there wasn't a pandemic. The same applies for 2012 Middle East respiratory syndrome coronaviruses, MERS COVID. So this was a local outbreak as well. So we never had a problem with those two viruses. It's just a matter in bibliography. But this virus is different. So it's the virus, the SARS-CoV-2, which causes the COVID-19 disease, which is the main of the main problem today. So regarding coronaviruses and how they are transmitted to us, if you see here, the primary reservoir is the bat, and the bat either transmit the virus to the camels. This is the MERS coronavirus, and through the Middle East coronavirus, and through the camels it is transmitted to people. The COVID-1, as we call the virus, it was transmitted first from bats to some animals, and from those animals to people. You cannot, as you see to this example, there isn't any direct transmission from bats to humans. So you need a host in between. And then from humans, either from in hospital or through community, it is transmitted to the rest of people. So you all know Wuhan, China is a city of a population of 11 million, so overcrowded, many people around, easy to transmit. And as you remember, it started, the first report was in December 13, 2019. There are countries that they did some autopsies, retrospective, and they found some people with coronavirus just before December 30. The coronavirus might be out there. We didn't know, during a winter, during winter, you have many pneumonias because this virus causes pneumonia. So you don't know if that is a new virus or it's, an old pneumonia. Usually we treat pneumonia empirically and not by cultures, because viruses or microbes are difficult to culture. And you see all this network of transportation from one continent to the other, so you can understand how easy from one country or from one continent to another, the virus can move really fast. So the transmission is largely made by close person-to-person transmission. So when we are talking about person-to-person, you see if someone coughs, how many droplets he produces. Airborne transmission is a matter of debate. Probably it happens. We aren't sure about that. And for many things I'm talking today, we will know exactly what's going on the coming months to years. So it's early to say what's going on. We are in the middle of an epidemic. So, medical society is trying to do its best. And the reproduction number, the RO as we call it, so every person on average transmit the virus, every infected person, to 2.5 persons. So the viral setting, as the virus, how the virus is replicated into a person. If you see here, this is the SARS-CoV-1, SARS-CoV-2, and this is a seasonal influenza. So what you see from this slide is that, on average, SARS-CoV-1, the 2002 coronavirus, it usually replicates, it needs about 10 days time after onset of symptoms. So on average, it needs 10 days till you have some kind of symptoms. This coronavirus, if you see here, it needs about 5 to 6 days. So for 5 days, those people are asymptomatic. Here for 10 days. So you have someone who transmits the virus, but he doesn't have any symptoms. On the other hand, you see here seasonal influenza, and you see that right away from the beginning of the infection, you have symptoms. So day 1, day 2. So gradually the transmissible of the virus goes down. The problem with this virus, as you understand, is that it has an asymptomatic period, so it's easily transmissible, and we cannot detect. The person does not know that he has the virus. Now, regarding the epidemiological characteristics of COVID in China, so I added an article from China because, you know, those guys have, let's say, some kind of central reports, and most of the reports come at the moment there. As you know, the disease is spreading around the world. So the severity of the disease, you see that 80% of the population, they are in mild disease. So maybe some upper respiratory symptoms like cough, you know, general symptoms like fever, maybe some sputum production. 15% of the population, they have severe disease, which means that you go to the hospital, you may need some oxygen and maybe some non-mechanical ventilation, but not intubation. And 5% is people who go to the ICU, so people who are intubated. And, you know, when you go to intubation, then things change dramatically for you. The age distribution, you see that 80% of the 3% of the age distribution, it's more than 80 years old, right? But here we have more casualties, right? Because those people are vulnerable. So not many older people are affected, but we have the higher percentage of death in those ages. You see the major source of infection is people between 30 to 80 years old, most of them. And you see that in young ages, you rarely see coronavirus. There are reports, there are deaths from coronavirus to young ages, but those are rare events. So regarding the clinical characteristics, you see that the incubation period, as we said, it's about 5 days. So after you're infected, after 5 days, you will have some kind of symptoms. So fever, cough, sputum, shortness of breath, those are no specific symptoms of upper and lower respiratory tract infection. It's flu, right? There are reports today about, you know, that it may affect the taste and, you know, the smell. People with isolated taste or smell, you know, problems, they are 3% of the overall population, so it's nothing. Usually it's combined with all these, you know, GI symptoms some people have. So let's say it's a virus that it affects many symptoms. It's not just the upper respiratory system. It's let's say the main area of infection, but it's not the only one. Regarding the laboratory and imaging findings, this is medicine here. So I would say that you need to concentrate on lymphocytopenia. So lymph cells, let's say, they are the main source of our defense against pathogens, either viruses or microbes. So this virus, for many reasons, it causes a decrease in number of lymph cells. So let's say it decreases our defense, you know, the soldiers we have for the battle, and it affects them also in not just in quality but in quantity as well. Now, regarding the imaging, so this is a CT scan of a person. This is the left lung, right lung, heart, and spinal cord here. So this is normal lung, as you see here, but there are those small areas here with white attenuation. That it's early areas of ground glass opacities, as we say. It's early pneumonia, and you see as you know, the infection involves, that's pneumonia here, and here. So as infection involves, you see infiltration of liquid, of virus, and of inflammatory cells of our body to the lungs. So try to understand that if you have a person who has normal lungs and he has a severe bilateral pneumonia, he will have some kind of respiratory distress. Now, if that person also have a damaged lung due to COPD, other diseases, his reserves are far less compared to a normal person. So that may affect him dramatically. The complications are many, and I can add a whole list of them. I added most of them. It's septic shock, so it's when you you have a problem, you cannot stay with a stable blood pressure, so your blood pressure needs help to maintain the normal range. ARDS is acute respiratory distress syndrome. So it's a form of pneumonia, as you've seen before. It's a form of bilateral pneumonia that needs mechanical ventilation. It causes kidney damage. 5% of the population need non-invasive mechanical ventilation. It's the severe disease, as we mentioned before, 15% of the people. And invasive mechanical ventilation, you know, the critical people, they are 2.3%. Use of extra corporeal membrane oxygenation. This is sophisticated equipment to help you improve your oxygenation. And death is 1.4%. It's far less than that. So this is a Chinese guy. This is a Chinese study. So it's an old study. My impression is that the death percentage, especially with so many asymptomatic people out there, it will be close to normal flu, seasonal flu. The characteristics of people in China is that 80% of the case fatality rate in people over 80% is over 80 years old is almost 15%. Remember, those people are 3% of the total people infected, right? But you see the high mortality here. The same applies for people 70 to 80 years old. And you need to understand that gradually we see not so many deaths, because people who are vulnerable would die early during the disease. So gradually you see more infected people, but less dead people. Usually, you know, people with cardiovascular disease, diabetes, COPD, hypertension, and cancer are, you know, mainly people who have high mortality due to low reserves of their body function. Now, regarding prevention and control measures, you know, we have strategies, you know them. It's containment and mitigation. You hear from them, and it's in public settings and healthcare settings. So you've all seen this curve. So what we try is to flatten the curve. So instead of having, you know, in a small period of time, you know, all these people coming into healthcare, and you may not be able to treat them all, you try to flatten the curve. So, you know, maybe the same amount of people or less will come to a larger period of time, so you will have time to prepare yourself. So you reduce the peak number of people, and maybe you reduce the volume of that, and you prepare better yourself. That's why you all stayed at home, because we could get this hit, but were we able to react to that? So regarding population-based mitigation strategy, so it's seasonal. As you all know, the seasonal influenza, what we do? We voluntarily home isolate ourselves when we are recommended non-PIs or non-pharmacological intervention. So we stay at home, we use masks, or we clean our hands, basics, right? And we clean the surfaces of the areas we live. So we try to isolate ourselves from our relatives. So during pandemics, if let's say we have a low or medium severity and transmissibility, you can do the same thing. But here we are talking about a pandemic. Many people are affected, and you know, many people will come to the hospital. So you try to flatten the curve. How you do that? You do that first with personal non-PIs, like voluntary home quarantine, the same. and face masks, and in community. So we do a lockdown everywhere. I understand that that's a medieval, let's say, strategy we use at the moment, but since it's a new virus, we don't have effective treatment or vaccine, and everybody is vulnerable to that virus, we use medieval strategies for the virus, unfortunately. And why you do that? To reduce the spread, reduce the load of healthcare facilities, as I told you, and reduce morbidity and mortality for sure. That's been proven. So transmission can be prevented in healthcare settings. This is mostly for people, at hospital. So minimize risk of exposure before arrival at hospital. Upon arrival, visual alerts, people who are sick, supplies, hand hygiene and masks to prepare them in the entrance, screening for signs and symptoms. If you recently been to a healthcare facility, they will ask you for COVID symptoms. And physical separation. I mean, you go to emergency department and they told you why you came here. Do you have fever or cough, or you came for another reason? And of course, limit and restrict visitors from the hospital, because we don't want, many more people to be contaminated. And in healthcare settings as well, we employ the basic principles of hygiene. Equipment, we need good equipment with droplet precautions like masks with eye protection. 10% of the transmission is from eye transmission. So this HCP health personnel. The contact precautions, gown and gloves, and aerosol generating procedures like N95 respirator. So N95, it is named because it protects from 95% of the droplets we get. There isn't 100% guarantee, but it gives, let's say, better protection than the ordinary mask. Now you'll tell me why they say that, doctors used to say don't wear a mask, then they used to say wear a mask, and there was this, people didn't know what to do. Well, if there is a shortage of masks, you start, from healthcare facilities, and you prioritize the masks for them, and then you go to the public. Now, the diagnostic test, who should be tested for COVID? You also know that, hospitalized patients, obviously, right? Any person, especially healthcare personnel, because those people may transmit that to other people, so we need to be careful with them. Everyone who has symptoms need to be tested. In my hospital, that policy applied. And symptomatic individuals who are at risk for complications, older people, people with the immunodeficiency and chronic medical conditions. And middle-ill patients, usually we say advise and stay at home, and maybe contact your healthcare provider and he can help you of how you go. Regarding the molecular diagnostic testing, I would say that here it's, let's say, the chain. So first you have the sample, right? And it goes to an automatic nucleic acid extraction machine. So that machine detects the RNA of the virus, real-time reverse transcription. It's PCR. And you have a certain results. If you see the timeline here, usually it's about 3 hours. Now you will tell me why it takes so much time. Well, it needs first to prepare yourself. Second, you cannot do every patient who comes every hour or every 30 minutes. You need to assemble a large amount of samples and then proceed with it, because that's cost, you understand. There is a cost, like everything. So I have seen here some results. So you see here in SARS-CoV-2 RT-PCR not detected, right? You need to be careful here, because negative results must be combined with clinical observation, patient history, and epidemiological information. You may have a negative test, but you may be positive for COVID, And that's a matter of, there are many false negative people who are out there. They may think that they don't have it, and we may repeat the test. Here you have a positive test, but you also need to understand here, there is an asterisk that, people who die with coronavirus doesn't mean that they died due to coronavirus. And there are also some intermediate, results, and usually we repeat the test. The sensitivity of the test, as you say here, the sensitivity is how good the test is to detect the virus. It's 33 at 4 days after exposure, 62 on the day of symptom onset. So usually when the symptoms started, you are highly contagious for others. And 80% 3 days after symptom onset. So it's the idea that the asymptomatic people, they transmit the virus, but the probability is lower compared to a person who has symptoms. And you understand why, because the person who has symptoms, he has, he has a high load of the virus. And as I told you before, factors that contribute to false negative test results include the specimen collection technique. As you see here, if you don't take a good sample of your throat, then you will have a negative result. Time from exposures, as I explained you here, and specimen source. I mean, lower respiratory samples, especially if you do it with bronchoscopy, you take a sample from your lungs. It's more sensitive than taking a sample from your throat. But we cannot do a bronchoscopy to every patient who comes to the hospital. So regarding the antibodies and all this discussion, you need to know that the presence of antibodies may not confer immunity, because not all antibodies produced in response to infection are neutralizing. And we don't know how frequently second infection with SARS-CoV-2 occur. We don't know that. And we don't know how much time we need to build antibodies also, although the idea is about 3 to 4 weeks. And how long the protection of those antibodies lasts, we don't know that either, unfortunately. There is some research done here to the institution I work. It seems like the antibodies are working, but for more severe cases, people with severe disease. In mild cases, the benefit you get isn't as much as you think. So the management, there is a difference here between the CDC, Center for Disease Control, and World Health Organization. They both say that with mild disease we may not require any initial hospitalization, and when it progresses, as the disease progresses, and it may cause pneumonia, that may affect your health, and you may need hospitalization. But you need to monitor that person closely, and you always need to individualize your action. And also, there are people who are old and who have chronic medical disease, lung disease, immunodeficiencies. Those people need special care, so we need to be very careful with them. Now, regarding the treatment options, you've heard some of these. It's antivirals and Remdesivir, antibodies, as I told you before, anti-inflammatory agents, immunomodulatory therapies, anticoagulants, because you may have heard that this disease causes strokes or a myocardial infarction. That's because it increases the coagulation of our blood, and also antifibrotic agents that we don't have data on that. They are in experimental state because there is the impression that COVID infection long-term may leave some scarring into our lungs, but it hasn't been proved. So, you need to understand that viral inhibition would be expected to be most effective early in infection, while in hospitalized patients, immunomodulatory agents may be useful to prevent disease progression, and anticoagulants, as I told you, may be useful to prevent thromboembolic complications like stroke and myocardial infarction. Regarding hydroxychloroquine, a lot of debate here, but from 200 trials that's already been done, the overall impression is that no trial has demonstrated clear benefit, and there are also adverse effects like arrhythmias and other cardiac complications. You also need to have in mind that hydroxychloroquine is a cheap drug used mainly for malaria and rheumatoid arthritis. So Remdesivir, you know, the new drug, it's an antiviral drug, and in this study of almost 1,000 patients, it was proven that Remdesivir had a shorter time to recovery than patients who did not take Remdesivir. But clinically, that might have, let's say, a slight influence to the overall outcome. I mean, instead of having, let's say, symptoms for 10 days, you have for 8, what's the difference for you? You understand? Clinically, it might not make any difference, because in medicine overall, what makes the difference is how many people survive and how many do not from that treatment. So be careful. I like a drug that helps you, it alleviates your symptoms, but if it doesn't improve survival, especially, to severe cases, then you need to be cautious. Another study here with almost 400 people found that the effect of Remdesivir on survival remains unknown. So we don't have clues that Remdesivir improves survival. Now, this trial, it's from UK recovery trial of 6,000 people. 2,000 people took dexamethasone, is a cortisone, is an immunomodulator therapy, and 4,000 people received usual care. So it's a randomized control trial, and this trial showed that people who were on treatment with dexamethasone, it reduced 30 days mortality to all patients. So that's a major, a major clue for our fight against coronavirus. Try to see here that I forgot to mention that dexamethasone was used in people who required mechanical ventilation. So people who require mechanical ventilation, as you remember, they are 5% of the population, and they are the most critically ill people. So in people who really have a problem, this drug showed that it improved survival. The previous drug, Remdesivir, it showed that it decreased the symptoms, but not in critically patients, in people who had mild or moderate disease. So keep that in mind. You also need to remember that minorities are affected more compared to other population, and you can understand why healthcare system here in the United States is different compared to other countries. Those people do jobs like bus driving or food service workers. They cannot work they cannot work from their houses. Black individuals, their accommodation, there are too many people in one place. I mean, even the area I am here, most of half of the population of people with coronavirus, they are Latinos. Regarding the vaccine, as you all know, there are about 100, more than 100 vaccines at the moment. Hopefully we will have a vaccine. As you remember, that vaccine will go against the S protein of the virus to So we will try to stop the virus. Hopefully, one of the vaccine will work. I mean, 100 vaccines working, we will have a virus. I don't know if what would be the efficiency of the virus, how efficient, how efficient the vaccine will be first, and second, what the availability will be. Because as you understand, let's say that we have a virus in September or October, you need to vaccinate about 1 billion people, right? How easy you vaccinate 1 billion people in the world? It's not easy, right? So you need to have that in mind as well. Here I have a final slide regarding coronavirus. So you see here from the onset of symptoms, as you see, most of people have mild to moderate disease and they go to recovery. 97% of the population, they go to recovery. And very few people from mild disease go deaf, some more from moderate disease, and people with severe and critical disease, it's easier to go to death. You need to remember that the death percentage is low. It's very low. It's close to the flu we have every year. But the problem is that we have a new virus. Nobody has immunity against this virus. We have a major outbreak. It can affect us all. So this 0.2 or 3%, you need to, if you multiply that by how many people are infected, that's an important number. And that is the end of my presentation. Thank you for your attention. And I would like to ask Thanos if you, or someone else, if you have 2 or 3 questions, please, because I'm a bit restricted with time. So thank you for your time.